Good evening, everyone, and welcome to our BetterBilling webinar series. Wait, what can I bill with that? I'm Helene, and I'm the Workforce Development Coordinator here at Westvic PHN, and I'm working alongside Jade, who's also works in our workforce development team. I'd like to begin by acknowledging the traditional owners and custodians of our unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations. A little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel, and the link to that is in the chat if you'd like to access that. Also, our upcoming events that are on the screen at the moment, and you can register for these via our website, and the link is also there. You may have seen that we've recently launched our new Learn and Network monthly newsletter. It's the best way to stay up to date with our latest education opportunities and upcoming events. If you haven't received an edition yet, please subscribe via the link in the chat or scan the QR code on the screen. Editions are released on the first Tuesday of each month. There's also a link in the chat where you can submit your education and training requests for the 2026 calendar, which we'll be organising in the next couple of weeks. Just a reminder about Health Pathways, our free online resource with localised clinical and referral information for health practitioners. A certificate will be emailed to you all, so if you can take the time just to check your full name is displayed accurately on the screen. If not, or you're not sure, just rename yourself and type your first and last name in the chat box. This way we can make sure we get your certificate. We are recording the event, so if you could keep yourself on mute unless you would like to ask a question. That will be at the end of the presentation. We do encourage interactivity and discussion, so feel free to type your question in the chat box and I can answer them on your behalf, or the presenter will. Or there may be an opportunity to take yourself off mute at the end of the presentation. Your feedback is also important, so if you could just take the time to complete the event survey, we'd appreciate that. So let's introduce our speaker, Dr. Ashley van Leeuwestyn. Over to you, Ashley. Thank you.
Thanks, Helene. Let me just share my screen one moment. Okay, perfect. So let me just pop this up on my screen, just making sure everybody can see and hear me, hopefully. So tonight is probably one of my most favorite talks I think I've done. So hopefully you guys find it informative as well. So this is about co-billing in general practice, and co-billing is one of the biggest questions I get asked all of the time from other practitioners or from practice managers, etc. And so hopefully this gives you a little bit of an overview of how I look at co-billing, and hopefully you can take some of this home to your practices as well and start to do some changes too. So what we'll do is we'll get started first, and this is going to be a reoccurring slide the whole time during this talk tonight. So to keep an eye on it, you're going to get access to these slides otherwise, or they'll be available on the YouTube channel afterwards. But what we'll be able to do is have a look at each of the item numbers specifically and look at their the co-billing rules around them. So if there's anything you take from this, it's this slide tonight. So what we'll see here is you'll see I've got some circles that are around the item numbers that I'm going to focus on and show you how you can co-bill them and how I do it as well. You see here we've got care plans or GP chronic condition management plans, a whole range of health assessments, your mental health care plans, your general attendances, investigations like ECG, spirometry, ABIs, follow-up nursing items, the DMMR or medication review, and the sexual health and reproductive telehealth item numbers, which we'll go through. Specific code to see at the top here is the split. So the stars are equal the need to split, and a hash is just for me to just say that I recommend doing these over different appointments, despite the fact that you could technically co-bill it. So what we're going to look at first is this column here on the care plans, and the second column here, which is 699, which is the heart health assessment. So you can see here you've got the face-to-face item numbers, and then you've got the video phone numbers, so if there are any video and phone numbers equivalent. So if we have a look at the care plans here, what can I be billing at the same time as a care plan? So yes, you absolutely can be doing a health assessment during the same time. So a 701 to 703, 705, 707. However, recommending that you're splitting that time in your consult, because you need to be able to show Medicare what time you used for the care plan and what time you used for the health assessment. The 715 and its telehealth equivalent can absolutely bill at the same time as a care plan, as can a 699, which is the heart health assessment, the 695 being the menopause health assessment, and your mental health care plans as well. General attendances, as you can see here in red, are not able to be billed at the same time. There are very specific requirements if you were to bill one during that same consult, but it would need to be on an acute emergency situation, and not for something that could technically wait up to 24 hours for the patient to be seen at another time. You can see here that you can absolutely free bill ECGs, spirometry, and ABIs, your nurse-initiated item numbers for care plans, and for 715s or after Aboriginal Torres Strait Islander health assessment, and the DMMRs or your medication reviews can also be flatly co-billed. If, for instance, you were doing a video-based telehealth care plan for patients, which you can do it via video, you can also claim a sexual health reproductive item number at the same time, but you'd be splitting it, okay? Having a look here at 699, so the biggest difference here is obviously you can do it with a care plan, which I'll show you how. One of the big things that I will touch on especially is about the fact that the 699 blocks out a large portion of health assessments that you can do under the 701 to 707 banner. You can technically be doing them with a 715 health assessment, but again, being splitting time and needing to show relevance as well. 695 or the menopause health assessment is the same. However, they both have time requirements too, as is with a mental health care plan. And as you can see below, you can flatly co-bill a medication review, the nurse-initiated items, and investigations with a 699. So let's have a little bit of a closer look at these two item numbers together and billing these together. So we're having a look at care plans. You're looking at, these are the old GPMPs or the new CCGPMPs now, or chronic condition care plans. And so this is the review or the creation of the care plan that I'm talking about here. So the patient has to have a chronic condition for more than 6 months, or will have it for more than 6 months. There needs to be goals and orientated for a team and follow up. If you haven't already, I recommend seeing my other webinars and courses around around the new changes with GPCCMPs. And what you can see here is the 3 monthly reviews. Now, in terms of an example, I've got a patient example here. So we've got John, who's 62, has come in for a diabetic review and a heart health assessment. Now, in some cases, I do like to do ECGs with my heart health assessments, particularly every 2 years. There is no need from a Medicare point of view to be doing an ECG. However, it's a good opportunity. At the same time, at this appointment, John ends up getting a Prevnar 13 from the nurse, and that is aligned with his care plan goal of keeping up with his vaccinations as well, or care plan task of keeping up with his vaccinations. Our nursing staff, in this case, have completed the initial assessment and documentation for both the care plan and the heart health assessment, including the BP, HbA1c, the lipids, and the cardiovascular risk percentage. As a doctor, we review the results, confirming the management plan, providing any counselling, and looking at following up the nurse-initiated further activities that might happen in 2-3 months' time. So having a look at the heart health assessment, the 699, a lot of people say to me, Ash, why would I bother billing this care plan, this item number with anything? Why would I bother billing it? It needs to be bulk billed. It's the same fee as if I was seeing a bulk billed patient for a 36. And if you're charging privately, this is not really, it's not really a good grab as per se. So what do I do with my heart health assessments? I always co-bill them. I think there's been one particular time where I might have billed it as an individual. However, I always co-bill this. So what do you actually need to do with the 699? So there are two requirements specifically from Medicare, and that is about having a blood pressure and a cholesterol check that's been recently done, and calculating the risk percentage through the Australian Absolute CVD Risk Calculator, which is built into a lot of our softwares, but also very freely available online. Anything such as discussing relevant history, risk factors, interventions if they need referrals done, if there's a management plan, if you're doing any other preventative health advice as well, that's also included in the assessment. The assessment itself needs to take a total of 20 minutes, and it's only for patients that are aged 30 plus. Now, this can only be done once every 12 months, however, cannot be claimed if you've completed other health assessments in the last 12 months. An exception to that is a 715. The 715 is able to have a 699 done for the same patient it can be technically be done at the same time. However, you would need to be able to clearly quantify why and how that they're not similar, and that they're two clinically not relevant item numbers. So this is how I do my care plan and 699 process. And for anyone who has seen my talks before or heard me speak before, you would know that I am a user of Lyrebird, and I quite like the software, and it's getting better and better, particularly around care plans. In terms of my template creations, you can see here, this is an example of one of the care plan templates that I have, which has now recently been updated with the changes. But you can see here, based off the consultation, it creates SMART goals, which are much more specific for the patient and what I consider to be audit proof. So they're very specific based off what my patient has talked to me about in that consult. It's created the care plan and the goal in this. It also has a general health and prevention section as well as a goal, just to make sure that you cover a lot of the preventative care that your nursing staff might be doing to claim that 10997 as well. What you can see here is the heart health assessment. Now, I really like the PDF in the heart health check risk assessment. This is relatively new from the Heart Foundation. It's only 3 pages, and it's done very well. And if you are a user of Lyrebird, you can actually upload this into the PDF documents, and it actually can be done what it actually can be done is pull data from the discussion that you've had in your consultation to fill out that PDF form. And that's normally how I will do both of them. So if I have a look here on the right-hand side, this is a bit about patient flow and what you can sort of expect in terms of where the patient is coming and what the process is. So say, for instance, in this case, my patient has attended the clinic, and we were talking about how John was going to see the nurse to complete the heart health assessment, the 699. Now, at the same time, my nurse has been able to see that the Prevnar 13 is due and has given the Prevnar 13. Also performed an ECG at this exact same time, because this is something that I also want to do. In terms of how I personally create the care plan, my care plan is created directly via my consult with Lyrebird and my discussions with the patient. There may also be a consult which is also created in terms of AI with my notes. So what you can see here is the billing item numbers for this attendance for this patient. So I've got a 695 for their care plan because that was due. I've also got a 11707, which is the ECG. I've also got a 699, which is the heart health assessment has been completed as well. And their Prevnar 13 has attracted a 10997 code from the nurse being able to initiate that vaccination. Now, for me, I'm often looking at ways to improve patient flow, etc., and having the nurse booking up in terms of the future appointments for whether they might need further vaccination, whether I'm wanting them to come and have a talk about blood sugar monitoring, whether there's discussion around insulin and in the need for that. There's always something I'm thinking about in the future of what is my nurse involved in their care in the future. So let's have a little bit more of a look at other health assessments. And specifically in this case, we're going to look at the 701 to 707. Now there's a range of health assessments which we'll go through here. But if we have a look back at the reference table, what we can see is, yes, we can be billing it with the care plan or a review. You can bill it with a 715. The reason I put this hash here is that the need to have these as very clear, distinct health assessments for separate reasons. And quite often there's a lot of overlap. In terms of these particular cases, I personally would do the assessments at different times of the year. There may be a at risk of diabetes or an at risk of chronic disease 705, and they may get their 715 done in 6 months' time after the fact. And I might use both of those item numbers for health assessments, which you absolutely can. In terms of the 699 quite often will block out other health assessment item numbers. And I'll show you a little bit in terms of flowchart, in terms of how to understand that. You can absolutely do a menopausal health assessment or perimenopausal health assessment. A mental health care plan can be done at the same time, but you'd be looking at a very large time burden of 20 minutes for the mental health care plan and whatever amount of time that you've chosen for your health assessment. Again, general attendances are not able to be done at the same time as a health assessment. They should be kept separate. ECG and investigations, nurse-initiated item numbers that are relevant for other tasks that have happened during that health assessment. So say, for instance, the health assessment itself cannot actually generate a nurse-initiated item or a 10997. You can absolutely claim your medication review if that process has also been done. And as health assessments, the 701 to 707 does not have telehealth equivalents, and therefore you can't be using the sexual health reproductive item numbers at the same time. So having a look at the different health assessments, you can see here on the right-hand side, these are the different levels. So 701, 703, 705, 707. For a lot of us, we're sort of aiming for those health assessments between 705 and 707, often with the help of our practice nurse. Then here on the left-hand side are the different types of health assessments that can be done for these patients. So you can see here there's the type 2 diabetes risk evaluation for people aged 40 to 49 with a high OS-risk score. So this is someone who's not diabetic, but they have an OS-risk score of more than 12. Then there's the health assessment for people aged 45 to 49 at risk of chronic disease, and they're able to have that just once. A health assessment for people aged 75 plus is annually. A comprehensive medical assessment for permanent RACF residents is also annually. Health assessments for people with an intellectual disability, also known as the CHAP assessment, can also be done annually. And you've also got once only health assessment items for health assessments for refugees and humanitarian entrants, or for those who are formerly in the ADF. So let's have a look at this little bit of an example here. And I've got Mary, who's an 82-year-old patient. She's got a background of hypertension, type 2 diabetes, osteoarthritis, and hyperlipidemia. And she's here today with her for her 75-year-old health assessment. And she's come with her daughter. And what you'll see here is the difference of how the work is sort of separated between both nurse and GP. You see here our nurses have 60 minutes in this particular case for an over 75 health assessment, where the RN is able to complete a large portion of the requirements. So the medical, surgical, social, and medication history update, which would already be completed by the GP previously. If there's a mini mental screen that's been done as well. And you can see here for Mary that's normal. If there's a psychological assessment, falls review about discussing specifically if there's been falls in the last 12 months, home supports as well, functional assessment, a preventative health review. So how many vaccinations has Mary had? Has she had her flu vax? What has she had or she not had? Then also the vitals and measurements, and particularly your base observations, BGL, a foot check if it's relevant as well. And also some care plan aligned education. So in Mary's case, she's also got a care plan that's around her diabetes, and there was some diabetes advice and risk reduction that was also completed during this time. Now, that is where the 10997 is going to come from. However, we've also additionally done an ECG during this time because of her age and her blood pressure. We wanted to get a baseline one done, which is also very helpful if you ever have an acute situation with this patient. She's in sinus rhythm and everything looks great. Then an ABI, if you have one of those machines, and you'll be able to see that because she's diabetic, she's an indication, and also her age, that we want to make sure she doesn't have peripheral arterial disease. And so we've got a normal ABI bilaterally, which has also been greatly done. Now, what you'll be able to see here is the GP then reviews the results, interpreting any health assessments or anything, any concerns that have come to light. Also looking at medications, if there's any sort of risk factor discussions around falls, etc., or what other requirements might be needed. And so what you can see here is in terms of the billing, we've been able to bill a 707 for more than 60 minutes with the nurse and the GP, a 11610, which is the ABI, a 11707, which is the ECG, and the 10997, which was the discussion around diabetes advice and risk reduction. So for in this particular instance, Mary's had a discussion around carbohydrate counting and trying to reduce her carbohydrates with my nursing staff, who's been able to provide her with some advice. Now, in total, if you were living in an MM1 or if your practice is in an MM1 location, you can see here that you're for that process entirely, you've got about $449 worth of billing for that patient, which 15 minutes of an appointment fee is quite a good effort. But also looking at this, Mary's had a really good preventative workup, and we can see that she's either tracking along really well or not. So the equation of health assessments, if there's anything that you find here, I really encourage you to look at this. So if you do a 699 heart health assessment on any of your patients, that will still allow you to have a 715 health assessment or an Aboriginal and Torres Strait Islander health assessment if your patient has that status. You will still be able to do a 695 menopause health assessment. However, it will block you from being able to do a 701 or 707 within that 12-month range. So quite often, we'll have a look into how this is implicated in the next example. These are things to be wary of. So let's have a little bit of a look at the 715. So the 715 is an absolutely awesome item number. It can be co-billed with a very large number of things, care plans, other health assessments, again, explaining I would do them over separate attendances. You can also be doing other health assessments like the 699 or 695. I would again be quite wary of the 699 purely because there's a lot of overlap between that and the 715 depending on age. The 695 or the menopausal health assessment can be also done at the same time, as can a mental health care plan. Again, no on the general attendances, yes on the investigation and nurse initiated items, and a medication review as well. So we're having a look at the Aboriginal and Torres Strait Islander health assessment. Now, this is can be done in the GP rooms or in the community, so this can't be done in the hospital or in the RACF. In terms of what is included, you're getting your full physical, psychological, and social assessment, your health, your history, examination, investigations as needed, overall assessment, your interventions and referrals as needed or what's come up. And you often can provide the written report to the patient as part of the process from Medicare. Now, I still use the NACHO and RACGP created PDFs, which are fantastic. But however, I do also have a created template in Liebird, which is available for free on my website if you'd like to trial it, purely based off the discussion that I have with my patient. So the key rules around the 715 is it can be done every 9 months, not every 12, every 9 months. It must be done by a GP. So the GP needs to be involved in this, and it should technically be done by the patient's usual doctor, but it can be done otherwise. Nurses and Aboriginal Torres Strait Islander health workers can assist, but the GP technically needs to be in supervision, for instance, is locally there or is in the next few rooms across. The bulk billing incentives are also able to be added. So if we have a look at the 715 here, this is an example of a 715 that I was able to do the other day. And this was about very careful planning of what this patient needed. So just for a a fictitious patient. Jared's a 42-year-old Aboriginal man. He has type 2 diabetes, hypertension, dyslipidemia. He's obese, he's a smoker, and he has low mood. And the reason he came in was we planned to do his 715 and his 967, or his care plan review, which was due around the same time. But he also came in to me to discuss some mental health concerns. You see here in the first portion of the nurse's discussion, they've completed the 715. So they talked about the full medical, family and social history, if there's this, if I haven't already had it. They've also done the psychology screening. In this case was a K10. Some OBS were done, a foot check in this case because he's diabetic, medications and making sure that he's still taking his medication, he's taking his metformin, he's taking his Forcedia, what's happening with that. Then also looking at a little bit of his ADLs as well. And they've identified today that his K10 was 29, so it was really quite high. His diabetes is still all over the place. He's not very good at taking his medication. He's really bad at medication adherence. And at the moment, he really feels like he's had enough. In terms of the care plan review, or the pre-work that my nursing staff's been able to do, they've reviewed the previous goals. They haven't, in this case, Jared hasn't really met them. They've updated the review of the type 2 diabetes status and the fact that he's currently looking at attempting to monitor with blood sugar levels, and about the new concerns. Now, the one in this particular case, we have fitted Jared with a Libre sensor, which was given to us to trial on patients. And Jared was someone I really wanted to get him a little bit motivated about checking his sugars and seeing it. And the Libre sensor was something we wanted to try. So the 10997 activity performed by our nursing staff was not the review of the care plan, because that's not able to be done, but the activity of popping the Libre sensor on the patient. Then in terms of the GP component, so I spent about 3 minutes reviewing the 715 as expected. If nothing was particularly shocking for me in there, and it was already on my radar. The care plan was something that I also reviewed and could say, yes, we're still looking to get the HbA1c under 7%, doing some daily walking and getting him to take his medications every day, but we were still not particularly there. Updated some team care arrangements as well about, where are you at with the dietitian, really pushing him along to go back to exercise physiology, and offering the updated care plan as well. But the K10 was what triggered a larger assessment, which was about a mental health care treatment plan, which is absolutely able to be done at this time. Now, discussing it with Jared, he ended up with a quite moderate depression. There's no real concern around risk assessment, no suicidal intention or homicidal intention, and referred him off for his first lot of psychology sessions, and was going to discuss around an SSRI at follow-up. So from this exact consultation of this patient that I've seen, a 715 has been completed with the bulk billing incentive. A care plan review has been completed with the bulk billing incentive. The 10997 has been completed for the Libre sensor with the incentive, and the 2715 has also been done with the incentive too. And in an MM1 location for this one patient, that was about $613 for that appointment. All of this is absolutely relevant and very clearly documented, and is absolutely able to be billed at the same time. So let's have a little bit of a look at the 695, which is the perimenopausal health assessment, which is relatively new. This is a time-based health assessment, needs to be done over 20 minutes, similar to at 699. You cannot be doing this with general attendances. It is only a face-to-face item, but can be done at the same time as any investigations, nurse-initiated item numbers, and a medication review. It can be done with other health assessments, however, needs to be split in time. So if the two were being done at the same time, it needs to be very clearly documented the time that is spent on each. So let's have a look at the breakdown into this. So what must be included is, your history, your peri, postmenopausal status, their risk factors, contraindications to things like MHT, basic physical exams like BP, height, weight, BMI, investigations and screening, particularly cervical screening, mammograms, and your bone densometry or your DEXA scans, discussing around non-pharmacological options and whether hormone therapy or medication is an option for this patient as well. It also needs to be very much symptom managed. So I'll show you a little bit about the templates that I have created and how I make that something to watch. And then also discussing preventative advice. So whether that's about stopping smoking, reducing your alcohol, looking to lose weight. Key rules in this particular case, the GP must provide the assessment personally. They can be assisted by nurses and Aboriginal and Torres Strait Islander health workers with information collection, but again, only under supervision. So this cannot be done where the GP is just off-site. It must be delivered with the patient's regular GP as well, and no separate consultation is recommended unless there's very clear acute issues that have come along. This can be done every 12 months, and the fee is $101.90. So having a look at how this is the case, and this is a patient that came into me who was 47, and she was in a new relationship and she's attended for an STI check. And we've discussed around the new relationship, discussed any sort of risk factors and any concerns, and we tailored what the STI check needed to be done. We discussed that, and then also looking at safer sex options, talking around barrier use. And then at the end, she sort of said to me, I really would like to sort out my menopause. And I asked a little bit about what symptoms particularly. She mentions a whole range of symptoms, but sleep issue and hot flashes are the worst for her. And then having a look at her file, she's never had bloods. She's never had a cervical screening. There's a lot of things that are outstanding. So for me, I have encouraged her to come back. Now, looking at this patient particularly, there's opportunities for the next appointment. There's about 4 different options here. So for me, the 695 is definitely an option because she wants to specifically talk about menopause. 965, does this patient have chronic disease items that could be done at the same time? 699, this patient definitely could have a heart health assessment as long as she has her lipids done and will get a BP at that same appointment. Or could she be someone that's a candidate for a 705? So does she fit the at risk of chronic disease, or is she at risk of diabetes? So the deciding factors here is that there was no other care plan indication. So she really didn't fit the chronic disease mold for anything else. The patient was very keen for a general health check and said she's very much overdue, would like to see where she's at with her diabetes and cholesterol. MHT, hormonal therapy, is something she's definitely interested in trying. And her Oz risk is 11. Now, in this case, for a 705 for at risk of diabetes assessment, the Oz risk needs to be higher than 12. And in this case, hers is 11. So this leaves us with the best opportunity in this case is doing the 695 and the 699 together. And so my plan was that the nurse will help me with information gathering for both the 699 and the 695, and I'll review both assessments personally and provide the management plan. So in terms of what happened, you can see here the nurse activities was the heart health assessment and completing this form for us in the PDF. You do have a large number of templates that you can access that work directly with BP. I personally use Lyrebird for mine, but it's another option as well. And here is the created menopause health assessment template. Now, this one is available on my website, completely free, and you don't have to be a paid subscriber to access this, and you'll be able to see it straight away. And what that helps is it just goes through the entire section of what I'd like the nursing staff to do, and then the remaining section of what you as a clinician is deciding to do. In terms of the activity that I was able to do, I completed the intervention for 699, which in this case was actually that she's relatively low risk for her heart health assessment. However, at this stage, my recommendation was that we needed to sort of decrease her cholesterol levels with, weight loss, increasing fiber supplementation, etc. And for the 695, the menopausal health assessment, she was somebody that actually was able to start MHT. However, I did not start that as of yet until the CST and her mammogram, particularly in this case, was done before starting it. So, and that was fine for you to be able to claim the 695. You do not at any point have to provide MHT to claim the 695. Okay, so let's have a little bit of a chat around the mental health care plan. So the mental health care plan is a time-based item. So you have 20 minutes or more. Care plans can also be 40 minutes or more for the 2717. And what you can see here is completing it with health assessments or any other item number, it needs to be split because the mental health care plan itself is a time-based item of at least 20 minutes. General attendances cannot be happening at the same time unless it is acute and urgent. And as usual, you can claim investigations, 10997, 10987, or a medication review at the same time. So how do I do my mental health care plans? As expected, it is again through the AI systems and through Lyrebird. So in this case, I've seen Sophie, who's a 34-year-old woman, and in terms of her chronic condition, she's also got chronic migraines. She was getting 15 headaches per month, which is a large burden, really. And she came today because we were reviewing her existing migraine care plan because we had started her on some medication for prevention, and also discussed some worsening anxiety related to migraines and is wanting to get some mental health support or psychological support. So you can see here on the left-hand side is the mental health care treatment plan that's created through Lyrebird, again, all through discussion, and it's very, very good. I recommend just having a look or even trying it is a really good option. Then what you'll see here is on the right-hand side is my consult with Sophie. And you can see here Sophie's having 15 migraines per month. We've also discussed some exercise might be beneficial, but she's really unable to deal with it. She's decided she's going to do her propranolol daily from tomorrow. And if not, we're thinking maybe Botox if it's ineffective. Then what you can see here is the care plan that's been created. So the care plan that's been created for Sophie in this particular case. You can see here what the goal is, and the created goal from the system is reducing migraines from 15 per month to 1 to 2 days per week within 6 months through medication management, lifestyle modifications. And you can see the specifics there around the goal and what we've recommended. So in this particular case, in Sophie's case, we've been able to bill a 965, or in her case, a 967 for a review of her existing care plan. And a mental health care plan, which was a 2715. Now we're going to have a look at some general attendance item numbers with the nurse-initiated following item numbers with the medication review. General attendance item numbers, specifically, you cannot be billing them with care plans and health assessments. If you think you have a reason to do so, I recommend that you tread lightly. Medicare has been very clear and very specific about the need to have a very clear documented reason for why a general attendance has been done on the exact same day. And so tread quite lightly. In terms of follow-up nursing item numbers, these are awesome item numbers. They can be billed with anything. So you can see here we've got face-to-face item numbers, but what a lot of people are unaware is that there are nurse-initiated item numbers with video and phone as well, if your nurse is helping you with video or phone. Medication reviews are a face-to-face item and can be billed with anything that is also face-to-face. So let's have a look at an example. So in terms of the medication review process, quite often people say to me, can you explain to me how this works? So when you have a patient and you're identifying the patient, at the moment, the change in Medicare's criteria is that you only need to have a patient with a chronic health condition or is taking medication and they're not having a great response, or they would benefit from a medication review. So at the moment, we are able to do this quite easily in comparison to what we previously were doing. In terms of consent, you're consenting the patient about, one, the fact that it's done at home and that you're going to share their information with a trusted pharmacist that you use for your medication reviews, and that a report will be sent to the chemist once we've completed this about their medication. You complete the referral, which I have a few referral templates available on our website as well. The patient is interviewed and a report is generated from your medication pharmacist. It will be sent back to you. You discuss the plan with the patient specifically and say, oh, my pharmacist has said here that you're not actually really been taking your antihypertensives, or you stopped taking your statins, I wasn't aware, etc. They will, and then after that discussion happens, you can now email a medication review report to your patient, the pharmacy that they attend as your mean of communication, and then you can claim the 900 item number. In terms of nurse-initiated item numbers, the ones that you need to know are specifically here on this table. So 10987 and 10997 are different. The reason for is their follow-up item numbers after a care plan or a 715. So the 10987 is the follow-up item number after a 715. There is no minimum time the nurse needs to spend with your patient. It can happen 10 times per year. The patient does not need to have an active care plan or review within 18 months. They have had a 715 done recently within the last 9 months, and they do identify as Aboriginal or Torres Strait Islander. Now, the difference with this item number here is that you as a GP do not have to see that patient technically on the day. If they are seeing the nurse for something and you feel comfortable and you're happy with the management, then that is fine. You don't actually need to see the patient. However, if you do see the patient, you can do so for what other item number that attracts. The 10997, however, is a 10997 is a follow-up item number after a care plan is completed. They occur at 5 times per year, and the patient has to have an active care plan or a review done within the last 18 months. The patient also has to see the GP face-to-face or via video or via phone that day. So they do have to see the GP. It can't just be done without direct contact on that day. And for those who are providing antenatal care, midwives, nurses, or Aboriginal and Torres Strait Islander health workers who are providing some antenatal care on behalf of GPs in rural and regional areas, the 16400 is another option that can be done 10 times per pregnancy. In this particular case, if you're providing antenatal care in these rural and regional areas, if you provide the 165-400, the GP cannot claim the antenatal code on the same day. So it needs to be one of you, and the GP item number is more in terms of billing, and so you would end up going with that. So chatting about the 10997, the biggest thing is this can be performed by a nurse or an Aboriginal or Torres Strait Islander health worker, and it is done so under the supervision of a medical practitioner. The patient has to have an active care plan or GPCCMP or a multidisciplinary care plan, and the services must be relevant to the goals created in the care plan. So what are some of the activities that your nursing staff can be doing with your patient to claim a 10997? Chances are, if you audited your day-to-day, you would see that there would be quite a few opportunities, but you just may not be aware. So these are some examples that I was able to get over a 3-day period of what my nursing staff have been able to do for a patient that attracted a 10997. So checking in on weight and measurements for weight loss for a diabetic patient, checking how your diabetic patient is going with administering their insulin, checking in on medication, DAS21 for mood progress, Prolia for an osteoporosis patient, depots and ABI for those who I was concerned were a risk of PAD, Prevnar injections for those who have COPD, influenza vaccination for a child who's asthmatic, collecting information to support other sort of reviews or care plans, whether that might be the DAS21 or that might be other sorts of information that I specifically am looking to complete in the tasks. If there was a completed health assessment that was a requirement of the care plan, so say for instance, or any activities are related to that. However, using 10997 for creating a new care plan or a review is not what it's designed to be used for. So this has been very, very clear since the change of the change to the GPCCMPs. And so specifically, you cannot use your nursing staff for creating or reviewing care plans and just billing a 10997. There needs to be a clear activity that was done separately. The 10987 is very similar. So all patients who have had a health check, the 715, completed by GPs or DMOs, GP supervision is required, but they can be remote. Again, 10 times per year, can be claimed with a bulk billing incentive item number, and also can be provided by a GP nurse, an Aboriginal Torres Strait Islander health practitioner as well. So let's have a look at a bit of an example of how this could happen together. So Linda's a 58-year-old female. She has hypertension, osteoarthritis, and hypothyroid. She's here for a routine check, and she's worried about her blood pressure and some medication. And she's had a medication review as well. So my nurse has been able to do a 10997 component for me, and that's been about checking her vitals. So blood pressure 152 and 88 and a heart rate of 78, checking on weight and lifestyle review. My nurse specifically has provided some blood pressure education and discussed around home monitoring, so different times of the day, what that looks like, and given an information sheet for that, and have documented their findings, and specifically let me know about that she's not really good at taking her blood pressure medication. Then I've been able to see her and have a chat with her in terms of review. So I'm having a chat with her about her symptoms. She's starting to get headaches and morning stiffness and fatigue. Checked the blood pressure myself again. It's 150 on 90 again. Having a chat whether that might be about sodium intake, weight management, and doing her osteoarthritis exercise, and looking at following up and monitoring her a little bit more carefully because she's just really not being able to improve, whatever that might be. Then I've also done the medication review, which is the 900. And my medication review is being able to be seen that these are the 3 medications she's taking. She's taking her amlodipine, her levothyroxine, and she's taking PRN ibuprofen every so often. And she's really not good at the amlodipine. She really hates it. Her legs are just swelling up with fluid. And it's really annoying her. And she goes, I just don't want to take it. So we have a chat about, do we look at changing dose? Do we increase it? Do we switch to something? And she says she just wants to give it a crack first before we trial something else. And so our plan is see how she goes in 6 weeks and repeat her blood pressure then. So this item, this attendance has attracted essentially a 109.97 from the nurse here with the bulk billing incentive. I've also done a 23 in this particular case, and I've also bulk billed it for that bulk bill incentive. The 900 has also been completed because I've provided the report over to the pharmacy, and that's also attracted a bulk billing incentive. And you can see there that's about 297.70 in an MM1 location. Okay, so the last bit is around split billing in general attendances with phone, video, and sexual health reproductive item numbers. As a female GP, I would bill this at least 3 or 4 times per day. I would say at least. If you are also a female GP or a GP that does a lot of sexual and reproductive health, you should probably be billing this too. So have a little bit of a listen to this. So in terms of general attendances, these are specific to phone. So unfortunately, these do not have face-to-face item numbers. So any item number that is a face-to-face item number, so a face-to-face general attendance or a health assessments or a mental health care plan that's not that is face-to-face, or a care plan that's done face-to-face, you're unable to do so. However, in terms of the phone or video general attendance, you can be claiming these at the same time. There is also a 109.97 or a 109.87 in phone or video that can be done at the same time as well. However, specifically with the sexual health and reproductive item numbers, they always need to be split because they are time-based. So if you're putting 2 general attendance time-based item numbers together, they absolutely need to be split billed because you need to tell Medicare how much time you spent on each and how they have not been relevant to each other. So let's have a look at an example. So these are the sexual health and telehealth item numbers. This is a direct copy and paste from our cheat sheet, which is available free online through our free templates area. And you can see here that these ones here in the middle column are video, and these ones here are phone. And they are the fees that are related to those attendances too. So what is the phone or video consultation can include? So anything that is history taking to do with sexual health and reproductive items, arranging investigations, implementing a management plan, providing any preventative health advice that might be related to sexual health or reproductive health. IVF or assisted reproductive techniques or antenatal care cannot be billed under this item number. It's the 2 things that you can't bill this for. And what you'll be able to see, there's a very large number of them for both GPs and other medical practitioners with video and phone numbers. Here, these are for GPs specifically, and they correspond directly with levels A, B, C, and D. So let's have a look at a patient example. And this is Michael, who is a 27-year-old. And the reason for the call was we wanted to check in on how his asthma was going since we changed around his puffers. And he also mentioned the need for an STI screen in the call. So for the first 6 minutes, we talked about the asthma review. It sounds like it's very well controlled. He's using spacer and is also warming up before exercises, which is kind of apparently helping him with his breathing. But at this moment, we're really happy with the inhalers and how he's going. He's really compliant, and so there's no need for change for treatment. And we'll just see how he goes in the next 6 months. The sexual health component is that he mentioned there was a new partner with some mild dysuria. Now, this is kind of the reason and he really wanted to make the call, and he wanted to mention it. So he's a little bit concerned because there was a condom break, and he's just really worried that he's got HIV. That was his biggest concern. Talking to him, there was no real concern around HIV. However, we've definitely gone and done a full STI check for him just for making sure that he feels comfortable with it, and provided that pathology referral. So having a look at exactly how I would process this in my billing, I would write this exact line, particularly to reception staff who are processing our split billing. You can see here I've bulk billed all of the item numbers just for simplicity. You can see the bulk bill item number of 109891 is the general attendance for the asthma, plus the bulk billing incentive, and split with 92734, which is the sexual health component of more than 6 minutes on the phone, which has also attracted a 10990 in an MM1 location. So you can see here for this call, that's actually totaled to about $121 for that discussion. And so splitting in this case is quite a big financial increase if you start doing this correctly for those who are always doing phone calls or who are always doing sexual health and reproductive medicine. So thank you very much. That was a bit of a longer one than my normal standard. So biggest thing from here, free templates are available on my website. You're very welcome to go and have a look now. That's on the main page. You'll see free templates. Jump straight in. You don't need to be a paid member. If you are also interested in Lyrebird, only recently I have had a discussion with them and said, look, I use the product. I'm a paying subscriber. I don't get it for free or anything like that. Give us a coupon code so that I can try and get some money off of some people. And so if you are interested or any of your GPs are looking to, BB Ashban 5 will get you 5% off, which is a decent amount if you're paying a big annual subscription. But I will open the next few minutes to any questions that anyone might have. I could see the chat going off, so I might actually have a look at the same time. Okay, so hi, Ashley. Well, okay. My website is just there on the QR code that on the top side, oh no, it's actually at the bottom, sorry. So hi Ashley, if claiming 699 or 707 excludes the other one from being done with 200, should we be aiming for 707s as this is a higher rebate? Absolutely, absolutely should. I was of the understanding previously claiming after 699 you could still claim 707, but not vice versa. No, so what will end up happening is that you will get a block. So when you see the patient and they have that OSRIS score, particularly in that group that's the 40 to 49 at risk of diabetes, this is the group that I quite find this with, is when you see them and you think, oh, they'd be great for a heart health assessment, one of the first things you need to think about is, do they actually fit the criteria for an at risk of diabetes assessment? Because that's going to pay you substantially more if you do a bit of time with the nurse and some time with the GP, and you're looking at a 705 or even a 703, that's going to be more than what you can attract with a 699. We attempted to do our own template for 715s, but medical director wasn't capturing the data correctly for our KPIs. We had to revert to the medical director template, and our stats were low even though we had done the work. That is very annoying, but yes, I could see how that would be the case. Hi, can we bill these, if possible, according to the co-billing chart with privately billed 23, 36, 44? If you want to just let me know what specific ones you wanted to ask about, just pop it in the chat or you can have a look. Can you charge a 10997 with a 965, e.g. if you gave a Prevnar at the same time? Absolutely. Okay, so this depends. I shouldn't say absolutely straight away. You need to have the care plan created before you can charge a 10997. So if you make it clear in the documentation that you have created the care plan, and as part of the care plan is to have vaccinations up to date with tasks with your in a task that your nursing staff are particularly responsible for, and that has been created, and then you actually provide the Prevnar, then you can then I see no problem with that, but it needs to be very clearly documented that the care plan was created first before the 10997 was. Okay, any other questions in the chat or anything like that? No, you cannot privately bill a 23 and 2715 as a bulk bill. So this is happening a lot, and Medicare specifically have made this really clear. So when you're doing a mental health care plan, health assessment, any of those things, you cannot see the patient for something separate and charge a private 23 and then do a care plan. And then do a mental health care plan. They cannot exist together unless you have a very acutely unwell patient that you need to speak to urgently about some other medical item that can't wait about 24 hours. If that is the case, then absolutely. But if not, then no, you can't. Perfect.
Hi, everyone. We do have a little bit of time, so if you've got any question or you want to take yourself off mute, please do so now, or type it in the question box. This is our second last webinar with Ashley for the year, and our next one is, I think it's the 11th of December, before our new series will start next year. So thank you. We've got all the questions in here. So thank you again, Ashley, for the great presentation, and we will see you again in December, and we'll see everyone else in December. Thank you all for attending.
Thanks, guys. Bye.
Bye.